My name is Cindy Callahan, and I will be presenting The Uncertainty in Illness Theory by Merle Michel. Merle Michel is a Boston native and graduated with her BA in 1961. She also graduated her MS in 1966, completed her MA in 1976, and completed her PhD in 1980. Over the years, she was recognized for various awards and was a member of various professional organizations as well. Her theory, the uncertainty in illness theory, originated in 1988 but was revised in 1990. It was developed originally to understand uncertainty in illness. There are two different models, her original model and the reconceptualized model. The uncertainty in illness theory can be classified as a mid-range theory based on its origination from clinical practice, its specific focus on uncertainty in acute and chronic illnesses, and its role in contributing to evidence-based practice as well. Merle Michel was an acute care nurse early on, right after graduation, but became a full professor at California State University. She also practiced as a nurse therapist and was a professor at University of Arizona in 1981, as well as a professor at the University of North Carolina in 1991. The theoretical sources she used to create her theory include existing information, processing models, discussion with colleagues, clinical data that she obtained from research, stress and coping literature discussing uncertainty, Norton's 8 dimensions of uncertainty, and then the ideas also of cognitive psychologists Bauer, Shalit, and Dugner. The chaos theory was used to also modify the original theory. The theoretical sources, information obtained, led to the development of Michel's uncertainty and illness scale. It also influenced her views of uncertainty. She had a new view of uncertainty as a stressor or a threat, which helped to develop the model. And the chaos theory, which she used to revise her original model. And it helped to include those that suffer from chronic illnesses or life-threatening diseases. Empirical evidence, research findings by Michel formed her foundation for the theory. Research on social support availability, the nature of the illness, interactions with healthcare providers, whether or not they trust their providers, quality of life affected the uncertainty negatively, and then the reconceptualized model, research of chronic and life-threatening illnesses. Primary sources used was the Middle Range Theory for Nursing book that was published in 2008. Also used journal articles, Uncertainty in Illness and Reconceptualization of the Uncertainty in Illness Theory, as well as a section of an encyclopedia titled Uncertainty in Illness. The nursing metaparadigm, the nurse, patient, environment, and health are the four sections of the nursing metaparadigm. The nurse is the provider of care, the person that's providing the care to the patient. The patient is the person receiving care, but also extends out to the family and the community as well. The environment is the external factors that are manipulated by the nurse. And then the health is the goal of nursing, or the optimal state of well-being for the patient. Central concepts and definitions include uncertainty, cognitive schema, stimuli frame, structure providers, and cognitive capacities. Uncertainty is defined as the patient's inability to subjectively interpret an acute or chronic illness, prescribe treatment plans, and or hospitalization, is unable to accurately predict outcomes. The cognitive schema is the view of the patient with regard to the acute or chronic illness, prescribed treatment plans, and hospitalization. If a patient is unable to form a cognitive schema, uncertainty can easily develop. The stimuli frame refers to the patient's perception of the stimuli, form, composition, and structure, and consists of three elements: the symptom pattern, the event familiarity, and the event congruence. The structure providers consist of available resources to the patient. Whether or not they have education, their education level is part of this, their social support, whether or not they have support, their family, and incredible authority as well. Cognitive capacities are the abilities of patients to process information, whether or not they are able to actually process the information they're given and understand the education that they're taught. That's the cognitive capacities. The central concepts and definitions are continued here with the inference, illusion, adaptation, new view of life, and probabilistic thinking. The inference is the use of previous experiences to evaluate uncertainty. So based on what they've been through in the past as far as their illness goes. Illusion is the beliefs that are formed by uncertainty. And adaptation is the goal. That's what occurs when effective coping strategies are used. And a new view of life is established at that point. New view of life refers to the acceptance of a newly formulated view of life based on probabilistic thinking. And the probabilistic thinking is the patient having the ability to view choices and alternatives as possibilities, in addition to accepting the concept of uncertainty as a part of life. Major assumptions in theory: recognizing uncertainty as a cognitive state, also recognizing uncertainty as a neutral experience. The desired outcome, obviously, is adaptation. Relationships are unidirectional and linear in the presence of illness, uncertainty, coping, and adaptation. Theoretical assertions, propositions: uncertainty tends to prevail when one is unable to form a cognitive schema. Again, that cognitive schema is the view of the patient with regard to the acute or chronic illness, how they view their illness. Uncertainty can be complex, it can be unpredictable, it can be inconsistent and ambiguous, and can lack information. Increase in stimuli frame and adequate structure providers results in a decrease in uncertainty. So when they have family support and social support and are able to get through an illness, and those things are increased in their life, then the uncertainty level decreases at that point. Additional theoretical assertions and propositions: the patient's perception of uncertainty affects their level of uncertainty, depending on how they view their illness. Effectiveness of coping strategy also affects the levels of uncertainty. So if they're using coping strategies but they're not using them correctly, that could affect their level of uncertainty. If they're using the coping strategies and using them correctly, that could also affect their uncertainty in a more positive way. Ability to function affects the longer uncertainty continues in illness. Acceptance of uncertainty as part of life is development of a new view of life, which is part of the adaptation process. Uncertainty can also have a negative impact on the quality of life. In summary, the goals of the uncertainty and illness theory: it stresses the importance of recognizing level of stress in acute and chronic illnesses in patients. Very important is education of patients on coping strategies to decrease their uncertainty level, and then aiding in management of uncertainty by providing adequate and appropriate support. These goals are easily accomplished by the organization of nursing interventions and promoting optimal adjustments, providing for use of evidence-based nursing. This is the schematic model that accompanies Michel's uncertainty and illness theory. As you can see, the stimuli frame, the symptom pattern, event familiarity, and event congruency. These things are all affected by the cognitive capacities of the patient, also affected by the structure providers, the credible authority, social support, and education of the patient. When these things are not in place, uncertainty can definitely prevail. From there, if the patient views the uncertainty as danger, then it moves on into the coping strategies and how well they're able to cope. If they're able to cope well and they're able to control their uncertainty, then adaptation occurs. Obviously, if they accept their uncertainty as opportunity and they see that, then they're able to also use those coping strategies and reach adaptation at that point. Adaptation is the goal here to move on into the new view of life. The logical form, the theory. The theory is neither inductive nor deductive. It's built upon systemic qualitative and quantitative research conducted by Michel and others. Empirical tests conducted by Michel and others also help to develop this theory. The identified flaws in the theory: the original model did not account for patients with chronic illnesses or life-threatening illnesses. So the theory itself was reconceptualized by Michel herself, and a new model came to play at that point. Also, another identified flaw: there's the nurses, where they lack the time, the ability, and the tools necessary to educate their patients There's this particular flaw is much more difficult to remedy due to the fact that there is always understaffing. Nurse-to-patient ratios are high, the lack of funding in healthcare, and then nurse burnout, where they're just fatigued and they're just ready to go home. Education tends to take a back seat. Nursing research, this theory in research, it lets us know that uncertainty is measurable. The development of the Michel Uncertainty and Illness Scale helps to measure patients' uncertainty and illness. The measurable uncertainty leads to research revealing evidence-based practice that is important to clinical practice where nurses are concerned. In education, it's important that health providers get educated, and they need education on how to measure uncertainty, how to address a patient's uncertainty, how to effectively listen to patients, how to teach patients effective ways to manage uncertainty. Unfortunately, nurses are just hired and they're just put on the floor and they're put there to work, and they're not taught how to take care of their patients in the best way possible. In practice, delivery of the relevant information or patient education is critical in patients managing their uncertainty. If patients aren't given the correct information and the information they need regarding their diagnosis and how to manage it, uncertainty is going to be high. The ability to measure uncertainty and evidence-based practice is also part of the theory in nursing practice. Implications for advanced practice RNs: we have the training, education, and ability once we graduate to apply the uncertainty and illness theory in clinical practice. There's a variety of settings the theory can be used, from inpatient to outpatient, acute care, hospice, home care. All of these settings can be places where this theory can be put into place. We need to thoroughly listen to our patients, take our time with them, let them talk. They need to know that we are interested in what they have to say, and know that we are interested in how they're feeling, and we need to spend adequate time with them. We also need to take the time to educate our patients. It helps to ease their anxiety levels, the uncertainty levels of them and their families. We need to teach them coping strategies. We also need to teach them about their diagnosis. The more they know about their diagnosis, the less uncertain they're going to be about it. My clinical scenario that I chose was based on a personal experience. I chose a child of a newly diagnosed retinoblastoma, which is a malignant tumor of the retina. In this scenario, the child should be measured for uncertainty. The child should be taught age-appropriate ways to cope. Coloring books could be given explaining the procedures that they may go through, anesthesia they may be given, MRI scans, things like that, chemotherapy. Also, age-appropriate videos could be given to the family for the child to view, or the child could actually view if they're in the healthcare setting in case they had questions. Parents of the patient of the retinoblastoma could, by their social worker, be put in touch with other families that have gone through the same diagnosis and have had positive outcomes. Simple but appropriate literature could be given so they're able to take it home and read it, and maybe come back with questions if they have those. Thorough explanations of all the treatment plans. This is going to be a lengthy process for this family, so thoroughly explaining everything is important. Also, with a new diagnosis like this, oftentimes families hear the information, but they're not able to process it, and they may need it to be repeated. So providers need to be aware that they may have to repeat information more than once to families of a diagnosis such as this. Also, a multidisciplinary approach needs to be followed here with physicians, nurses, advanced practice nurses, dietitians, social workers, therapists. These different specialties should be willing to communicate with each other, communicate with the family, and do everything possible to get this family through this diagnosis. In summary, healthcare providers are expected to assist patients in meeting their basic needs, and that includes uncertainty. Levels of uncertainty can be reduced by listening, educating, and providing ways to cope. These levels of uncertainty should be monitored and measured often, and the goal should be for patients to reach optimal state of well-being. Thank you very much.